Welcome to the podcast where great minds meet, which brings together visionary guests, from Chancellor Gary May and Dr. Robert Langer to Greg Zuckerman of the Wall Street Journal and Forbes 30 Under 30's Kyle Woom, to share insights on science, leadership, and purpose. Featuring pioneers like His Excellency Sidney Colley and Dr. Emery N. Brown, each episode dives into stories of resilience, discovery, and impact, celebrating the intersections of curiosity and greatness across diverse fields. Please note the views of this podcast represent those of my guest and I, and do not constitute medical or professional advice, suggestions, or consultations. Thanks again for listening.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Verse 1, disease to pathophysiology. From heart to lungs, the issues grow. Pathophysiology starts to show. Hypoperfusion, organs cry, oxygen drops, cells start to die. No turning back, no turning back. Chorus, pathophysiology. Shock states arise in 4 key streams. Hypovolemics, the blood loss theme. Obstructive blocks, flow is restrained. Distributive vasodilation's the name. No turning back, no turning back. Verse 2, drug treatment path. Dofetilide, keep rhythm clean. Beta blockers reduce the scene. For shock, norepinephrine reigns. Add vasopressin when goals remain. No turning back, no turning back. Chorus, mechanisms of action. Alpha constricts, beta pumps more. Vasodilation helps blood restore. Diuretics pull fluid away. Inotropes guide the heart's pathway. No turning back, no turning back. Verse 3, dosing warnings. Cardiogenic drops, adjust the dose, avoid the risks, keep the body close. Thiazides fail with GFR low, dabigatran's bleeding may show. No turning back, no turning back. Chorus, dosing thresholds. Above 30, adjust with care. Below that line, some drugs beware. Unfractionated heparin thrives, safer choice when kidneys dive. No turning back, no turning back. Verse 4, clinical insights. Fluid bolus if needed now. Balance crystalloids to make the vow. Monitor lactate, numbers don't lie. High doses can make maps fly. No turning back, no turning back. Bridge comprehensive flow. ACE inhibitors mend the heart. Beta blockers play their part. Anticoagulants for clotting risk. Choose therapy, be realistic. No turning back, no turning back. Outrow clinical mastery. From disease to treatment, guide the way. Clinical wisdom saves the day. With creatinine cleared and pathways sound, the rhythm of life in care is found. No turning back, no turning back. Verse 1, disease and pathophysiology. Atrial fibrillation steals the beat. Cardiomyopathy makes hearts retreat. Shock states arise, organs in dismay. Pathophys maps the clinical way. No turning back, no turning back. Chorus 1, understanding shock. Hypovolemic from fluid loss. Cardiogenic, the pump is lost. Obstructive blocks flow through the veins. Distributive spreads, resistance wanes. No turning back, no turning back. Verse 2, dofetilide and dosing guidelines. Dofetilide restores sinus flow, but CarCL must tell you where to go. Over 60, 500 twice. 40 to 60, 250 will suffice. If less than 20, it's contraindicated. Chorus 2, beta blockers save the heart. Post-MI or HFrEF, you see, beta blockers like carvedilol bring glee. Bisoprolol, metoprolol, they keep it slow. Dosing adjusts as CarCL goes. No turning back, no turning back. Verse 3, anticoagulants in renal failure. When CrCl drops below 30 lines, avoid dabigatran, it's bleeding time. Rivaroxaban, use 15 each day, but apixaban twice at 2.5 may stay. If creatinine climbs, monitor the way. Chorus 3, heparins and their role. UFH shines for renal decline, no reliance on clearance, it works fine. LMWH needs CrCl care, dose adjust enoxaparin, beware. 30 and below, go low and slow. Verse 4, diuretics and volume control. Thiazides fail when GFR is weak. Loop diuretics rise when swelling peaks. Furosemide starts at 40 milligrams, increase as needed, monitor the plans, ceiling dose adjusts as kidneys stand. Bridge 1, vasopressors for shock states. Norepinephrine's the first to choose, MAP rises, the vessels constrict and cruise, add vasopressin if NE won't do, epinephrine steps in for cardiac rescue. If tachyarrhythmias reign, try phenylephrine. Verse 5, corticosteroids and septic shock. In septic shock with vasopressor need, hydrocortisone 200 is the creed. Give 50 milligrams every 6, continuous infusion can do the fix. Vitamin C and thiamine, guidelines mix. Chorus 4, crystalloids and fluid choices. Lactated ringers or plasma light, balanced fluids win the fight. Avoid starch. Albumin has a role. For septic patients, it's a life-saving goal. Crystalloid first, then albumins burst. Verse 6, cardiogenic shock therapy. MAP above 65's the aim, inotropes like dobutamine join the game. For cold and wet, norepinephrine leads. Add milrinone when the heart concedes. Monitor SVR, adjust as needs. Bridge 2, antimicrobials in septic care. Broad spectrum hits infections fast, de-escalate once culture's cast. Empiric gram-negative double dose, add MRSA coverage when risk is close. Daily review, don't overuse. Verse 7, ACS and reperfusion goals. STEMI hits, the clock runs tight, PCI within 90 minutes is right. Aspirin, clopidogrel, start the chain, high-dose statin must sustain. Beta blockers follow when shock is tamed. Chorus 5, anticoagulants and ACS. Heparin unfractionated first-line stands. Enoxaparin works but needs skilled hands. Bivalirudin joins when bleeding's feared. Dual antiplatelets keep vessels cleared. Monitor INR for warfarin's gear. Verse 8, anaphylactic shock management, epinephrine IM. First line start, 1 dose in the thigh protects the heart. Antihistamines calm itching's plea, glucocorticoids, no strong guarantee. For low MAP, add a norepi spree. Chorus 6, creatinine clearance adjustments. CrCl above 60, standard dose, below 30, caution is close. Monitor labs, avoid the crash. Renal failure needs tailored math, no turning back, no turning back. Outro clinicians pledge. Disease to dosing we understand, pathways crafted by skilled hands. We'll follow science, we'll stay the course, saving lives is our steady force, no turning back, no turning back. Hypertension, stanza 1, pathophysiology. Arterial walls face pressure strain, increased resistance causes pain. Volume overload, renin too high, kidneys and vessels make BP rise. No turning back, no turning back. Stanza 2, drugs to treat ACE. Inhibitors like lisinopril, beta blockers, metoprolol fills. Hydrochlorothiazide, microzide in the mix. Amlodipine, Norvasc for calcium tricks. No turning back, no turning back. Stanza 3, mechanism of action. ACE stops angiotensin II's reign, beta blockers slow the heart strain, calcium blockers relax and flow, diuretics make the fluids go, no turning back, no turning back. Stanza 4, dosing guidelines. Lisinopril starts at 10 mg a day, adjust with CrCl if kidneys sway. Amlodipine starts at 5 mg per dose, no renal adjustments as it goes, no turning back, no turning back. Heart failure, HFrEF, stanza 1, Pathophysiology. Weak ventricles pump less flow, fluid overload makes pressures grow, ejection fraction less than 45 leads to congestion, hard to thrive, no turning back, no turning back. Stanza 2, drugs to treat, carvedilol, Coreg, for beta blockade, Entresto, sacubitril valsartan, and EF cascade. Spironolactone helps with RAS blockade, loop diuretics like furosemide invade, no turning back, no turning back. Stanza 3, mechanism of action. Carvedilol slows heart's demand, Entresto blocks RAS's hand, spironolactone cuts aldosterone's toll, loops clear fluid, diuresis is the goal, no turning back, no turning back. Stanza 4, dosing guidelines. Carvedilol starts at 3.125 twice a day, increase is tolerated in a steady way. Furosemide dosing 40 mg to clear, monitor CRCL, higher doses for low GFR, no turning back, no turning back. Pulmonary hypertension, stanza 1, Pathophysiology. Pulmonary vessels constrict and rise, RV strain as pressure applies, mean PAP over 25, blood can't flow, hard to survive, no turning back, no turning back. Stanza 2, drugs to treat, epoprostenol, Flolan, dilates well, bosentan, Tracleer, PAH to quell, sildenafil, Revatio, opens flow, riociguat, Adempas, helps pressures go, no turning back, no turning back. Stanza 3, mechanism of action. Prostacyclin analogs reduce strain, endothelin blockers ease the pain. Phosphodiesterase inhibitions gain, guanylata cyclase enhances the gain. No turning back, no turning back. Stanza 4, dosing guidelines. Epoprostenol, 2 ng/kg/min to start, titrate slowly, support the heart. Bosentan 62.5 mg, bid for ease, monitor LFTs, watch for disease, no turning back, no turning back. Acute decompensatory heart failure, stanza 1, Pathophysiology. Congestion fills, perfusion low, acute HF deals a heavy blow, pulmonary edema, pressures rise, cardiac output falls, tissues compromise, no turning back, no turning back. Stanza 2, drugs to treat, dobutamine boosts cardiac squeeze, milrinone helps when afterload freeze, nitroglycerin to relieve congestion, furosemide clears fluid retention, no turning back, no turning back. Stanza 3, mechanism of action, dobutamine beta-1 assist, milrinone PDE3 on the list. NTG dilates, reduces strain, diuresis clears excess again, no turning back, no turning back. Stanza 4, dosing guidelines, dobutamine 2.5 mcg/kg/min, titrate slow, milrinone at 0.375 mcg/kg/min may go. Furosemide 40 mg to begin, SARCL low, adjust doses within, no turning back, no turning back. Shock overview. Stanza 1, Pathophysiology. Circulation fails, oxygen low, perfusion wanes, organs slow. Hypovolemic, cardiogenic 2, distributive, obstructive shock ensue. No turning back, no turning back. Stanza 2, drugs to treat, norepinephrine, first line, strong and true, add epinephrine for cardiac rescue. Crystalloids rehydrate. Albumin aids, vasopressin stabilizes when response fades. No turning back, no turning back. Stanza 3, mechanism of action. NE constricts to increase MAP, epinephrine boosts cardiac snap, fluids restore circulating volume, vasopressin holds pressures in column, no turning back, no turning back. Stanza 4, dosing guidelines. NE starts at 8 mcg min or more, titrate to MAP, body needs to restore, fluids 30 ml/kg bolus wide, monitor lactate, MAP will guide, no turning back, no turning back. Dyslipidemia, stanza 1, Pathophysiology. Lipid plaques clog, arteries tight, LDL rises, HDL slight, atherosclerosis builds the wall, risk of stroke and MI for all. No turning back, no turning back. Stanza 2, drugs to treat. Atorvastatin, Lipitor, a potent pill, rosuvastatin, Crestor, lowers LDL still. Ezetimibe stops absorption start. PCSK9 inhibitors play their part. No turning back, no turning back. Stanza 3, mechanism of action. Statins block HMG-CoA. Less cholesterol is made each day. Ezetimibe stops absorption inside. PCSK9 recycles receptors with pride. No turning back, no turning back. Stanza 4, dosing guidelines. Atorvastatin high, 40 to 80 each night. Rosuvastatin moderate, 10 to 20 is right. Adjust for CKD if CRCL's in decline. Monitor liver enzymes every time. No turning back, no turning back. Atrial fibrillation, stanza 1, pathophysiology. Irregular rhythm, the atria quakes, blood pooling leads to clotting stakes, thrombus forms, stroke may ensue, rate and rhythm, control is due, no turning back, no turning back. Stanza 2, drugs to treat, warfarin, Coumadin for anticoagulants, apixaban, Eliquis controls the rolls, dofetilide restores normal flow, amiodarone slows the rhythm's glow, no turning back, no turning back. Stanza 3, mechanism of action, warfarin inhibits clotting's core, factor 2, 7, 10, and more. Apixaban targets his site, amiodarone blocks K+, sets rhythm right, no turning back, no turning back. Stanza 4, dosing guidelines. Warfarin aims for INR 2 to 3, apixaban 2.5 bid with low CRCL to C. Dofetilide twice daily, dose varies in flow, monitor QT, adjust as labs show, no turning back, no turning back. Venous thromboembolism, VTL. Stanza 1, pathophysiology. Clots form deep in leg or lung, immobility traps, damage begun. Virchow's triad describes the scene, stasis, injury, hypercoagulable being, no turning back, no turning back. Stanza 2, drugs to treat, enoxaparin, Lovenox in acute phase, rivaroxaban, Xarelto carries long days. Warfarin for chronic, INR to keep, fondaparinux for sub-Q, skin so deep, no turning back, no turning back. Stanza 3, mechanism of action, heparins bind antithrombins chain, XA and the CIA lose their domain. Direct ISA inhibitors block clot's path, warfarin resets the COG cascade math, no turning back, no turning back. Stanza 4, dosing guidelines. Enoxaparin 1 mg kg twice daily given, SAR-CL below 30, dose halved or even. Rivaroxaban 15 mg bid first 3 weeks after 20 mg daily the body seeks, no turning back, no turning back. Coronary artery disease or CAD. Atheromas block coronary flow, oxygen drops, ischemia shows, endothelial dysfunction takes its toll, angina warns of plaques that roll, no turning back, no turning back. Aspirin and statins for stability reign, beta blockers lessen ischemia's pain, nitroglycerin for acute relief, ACE inhibitors prevent future grief, no turning back, no turning back. Aspirin blocks COX and platelets glue, statins cut cholesterol through and through, beta blockers calm the heart's wild beat, ACE inhibitors keep vessels neat, no turning back, no turning back. Aspirin 81 to 325 milligrams daily dose, statins at high intensity go for the most. Beta blockers vary, titrate to rest, adjust ACE for renal, monitor the test, no turning back, no turning back. Acute coronary syndrome or ACS. Plaque rupture spills its lipid core, platelets adhere, the clot builds more, oxygen starvation, tissue begins to die, STEMI or end-STEMI, watch the EKG sky, no turning back, no turning back. MONA starts the life-saving thread, morphine, oxygen, nitro, aspirin spread. P2Y12 inhibitors like clopidogrel stay, anticoagulants join the fray. No turning back, no turning back. Nitro dilates to reduce demand, aspirin halts platelets in their stand. P2Y12 inhibits ADP's Q, anticoagulants stop fibrin 2. No turning back, no turning back. Aspirin chewed 325 milligrams first dose, clopidogrel 300 milligrams loading, then maintenance close. Unfractionated heparin 60 units per kilo. Adjust by APTT as levels grow. No turning back, no turning back. Types of shock, heart pump fails, cardiac outputs low, MAP drops, perfusion won't grow, norepinephrine first, dobutamine next, monitor hemodynamics, follow the text, no turning back, no turning back. Septic or anaphylactic, vasodilation flows, loss of tone, vascular collapse shows, epinephrine for anaphylaxis reigns, fluids and pressors ease septic veins, no turning back, no turning back. Tamponade, embolism block the way, relieve the source to save the day. Fluids maintain until cause is clear, surgical fixes save what's dear. No turning back, no turning back. Pressors start with norepinephrine, fluids 30 ml per kilo to begin. MAP above 65, the target set, monitor labs and clinical debt, no turning back, no turning back. Pulmonary arterial hypertension or PAH. Stanza 1, pathophysiology. Pulmonary pressure rises high, mean PAP over 25 implies. Preload is normal, but flow declines. PCWP measures the cardiac signs. No turning back, no turning back. Stanza 2, drugs to treat. Ambrisentan blocks endothelin strain, sildenafil known as Revatio boosts cyclic gain. Epoprostenol or Flolan for severe disease. Riosiguat, also called Adempas, makes blood flow with ease. No turning back, no turning back. Stanza 3, mechanism of action. Endothelin antagonists reduce constriction. PDE5 inhibitors, dilations, fiction. Prostacyclins enhance smooth muscle relax. Guanylate cyclist restores the tracks. No turning back, no turning back. Stanza 4, dosing guidelines. Ambrisentan, 5 milligrams daily to start. Sildenafil thrice daily, 20 milligrams part. Epoprostenol starts at 2 nanograms per kilogram per minute. Titrate with caution. Watch patient's skin. No turning back, no turning back. Ischemic heart disease, or IHD. Stanza 1, pathophysiology. Plaque narrows vessels, perfusion wanes, demand exceeds supply, angina reigns. Silent ischemia can harm unseen, chest pain warns, take action keen, no turning back, no turning back. Stanza 2, drugs to treat. Beta blockers like atenolol soothe the strain, nitrates like isosorbide ease the pain. Ranolazine, also known as Ranexa, reduces late currents, aspirin prevents the clots emergent. No turning back, no turning back. Stanza 3, mechanism of action. Beta blockers slow the heart's demands. Nitrates dilate, restoring bands. Ranolazine shifts myocardial flow. Aspirin stops platelets' deadly show. No turning back, no turning back. Stanza 4, dosing guidelines. Atenolol starts at 50 milligrams daily. Increases tolerated, heart rates tally. Isosorbide adinitrate 5 milligrams thrice per day. Avoid tolerance with nitrate-free play. No turning back, no turning back. Septic shock, stanza 1, pathophysiology. Infection spreads, immune runs wild, vasodilation leaves organs defiled. MAP drops, lactate starts to climb, resuscitation is urgent and prime. No turning back, no turning back. Stanza 2, drugs to treat. Norepinephrine for MAP to restore, add vasopressin when response is poor. Hydrocortisone helps when pressors fail. Broad antibiotics complete the tale, no turning back, no turning back. Stanza 3, mechanism of action. NE constricts and raises tone. Vasopressin mimics ADH zone. Hydrocortisone reduces inflammatory swing. Antibiotics halt microbial sting. No turning back, no turning back. Stanza 4, dosing guidelines. Norepinephrine starts at 8 mscuri min, titrate to 65 MAP win. Hydrocortisone 50 mg q 6 HIVOR. Broad antibiotics, empiric and lively. No turning back, no turning back. Anaphylactic shock, stanza 1, pathophysiology. Histamine bursts as allergens meet, vasodilation makes MAP retreat, airways close, swelling spreads, life depends on quick meds, no turning back, no turning back. Stanza 2, drugs to treat, epinephrine IM saves the day, diphenhydramine calms itching's fray, methylprednisolone may reduce the phase, IV fluids restore volumes blaze, no turning back, no turning back. Stanza 3, mechanism of action. Epinephrine binds alpha and beta sites, restores tone and opens airways tight. H1 blockers like diphenhydramine quell. Steroids calm inflammation spell. No turning back, no turning back. Stanza 4, dosing guidelines. Epinephrine 0.3 mg/IM, repeat if dire, diphenhydramine 25 to 50 mg prior, methylprednisolone I4 125 per dose, fluids bolus wide, watch perfusion close, no turning back, no turning back. Obstructive shock, stanza 1, pathophysiology. Tamponade stops the heart's preload, pulmonary embolism blocks the road. Tension pneumothorax traps the air, obstructive shock demands urgent care. No turning back, no turning back. Stanza 2, drugs to treat. Fluids bolster preload fast, fibrinolytics for clots that last. Surgical decompression relieves strain, inotropes assist when output wanes. No turning back, no turning back. Stanza 3, mechanism of action. Fluids restore what preload lost, lytics dissolve clots at a cost. Pericardiocentesis drains tamponade, tension air relief stops the facade, no turning back, no turning back. Stanza 4, dosing guidelines. Fibrinolytics, TPA at 100 mg dose, fluids 30 ml/kg wide bolus flows. Surgical intervention as tailored demands, monitor MAP with careful hands. No turning back, no turning back. Cardiogenic shock, stanza 1, pathophysiology. The heart can't pump, output's low, perfusion halts, pressures won't grow, congestion builds, tissue oxygen drops, inotropes and pressors must fill the stops. No turning back, no turning back. Stanza 2, drugs to treat, dobutamine for contractile push, norepinephrine for MAP to hush. Milrinone helps if afterload's high, nitro reduces congestion's cry, no turning back, no turning back. Stanza 3, mechanism of action, dibutamine's beta action boosts, Nebraska constricts as blood flow sluices, Milrinone PDE3 inhibitor reigns, nitro relaxes veins heavy chains, no turning back, no turning back. Stanza 4, dosing guidelines, dibutamine 2.5 mg/kg/min titrate slow Nebraska 8 mg min map will show. Milrinone starts at 0.375 mcg/kg/min, nitros 10 mcg min, congestion thins, no turning back, no turning back.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Podcast where great minds meet, which brings together visionary guests from Chancellor Gary May and Dr. Robert Langer to Greg Zuckerman of the Wall Street Journal and Forbes 30 Under 30's Kyle Woom to share insights on science, leadership, and purpose. Featuring pioneers like His Excellency Sidney Colley and Dr. Emery N. Brown, each episode dives into stories of resilience, discovery, and impact, celebrating the intersections of curiosity and greatness across diverse fields. Please note the views of this podcast represent those of my guest and I, and do not constitute medical or professional advice, suggestions, or consultations. Thanks again for listening.